Welcome to PTCB 2026 Dose Route Mastery. This video will prepare you for the Pharmacy Technician Certification Exam, covering strengths, doses, forms, routes, special handling, administration, and duration. We will review sample questions, deep explanations, and study strategy pearls. Master dosage calculation with the cross-multiplication and unit cancellation strategy, using the Honda method for setup. Be aware of exam traps, such as the insulin syringe trap, where unit cancellation is critical to correctly calculate milliliters per dose. The pediatric dosage calculation framework involves calculating total daily dose using milligrams per kilogram per day, then dividing by dosing frequency. For special populations like neonates and obese children, use ideal body weight and observe a cap at 150% IBW to ensure safe dosing. Be cautious with rounding rules to prevent over or underdosing. Percentage strengths are defined as grams or milliliters of solute per 100 of solution or mass. In dilution problems, like compounding a 4% solution from a 10% stock, always remember to calculate the diluent volume after finding the volume of stock solution needed. This diluent calculation is a common exam trap. The quick reference conversion is that 1% equals 10 milligrams per milliliter. When calculating IV doses, remember the overfill trap. Infusion bags often contain 10% overfill volume, which means the pump rate must be adjusted downward to deliver the correct dose over the set time. Distinguish between caplets and capsules, noting their common excipients. Scored tablets allow safe splitting. However, extended release or XL tablets must never be split due to the risk of dose dumping and legal liability. Enteric release is pH dependent, dissolving in the intestine. Delayed release is time-dependent, using polymer matrices for gradual dissolution. A critical warning: do not crush or chew these formulations, as it compromises the mechanism and risks rapid release or inefficiency. Orally disintegrating tablets or ODTs dissolve rapidly in under 30 seconds. Handle them with gloves as they are moisture sensitive and often used for the elderly or pediatrics. A key trap is transferring an ODT to a multi-use vial, which causes a significant stability drop because the desiccant must remain in the original blister. Review dosage forms. Solutions are clear, uniform mixtures. Suspensions are cloudy, particles settle, and require shaking well. Emulsions are oil-water mixtures that also require shaking well. Learn auxiliary labels, like refrigerate after reconstitution, as needed for amoxicillin suspension. Topical forms include ointments for dry skin, creams for general use, and gels for hairy areas. The rule of thumb for steroid potency ranking is ointment, then cream, then lotion. Be careful not to substitute based on patient preference alone, as clinical efficacy and potency must be prioritized. Oral administration is convenient and non-invasive, but subject to the first-pass effect, food delays, and acid lability. Key exceptions include levothyroxine, which is taken on an empty stomach, and tetracycline, which should not be taken with dairy. Fiber can bind drugs like warfarin, requiring separation by 2 hours. Sublingual administration has a rapid onset, typically 1 to 3 minutes, and bypasses the liver. Key points include not swallowing the tablet, which must dissolve completely under the tongue. Avoid drinking water immediately after administration, as this washes the drug away. IV bolus is administered over seconds, providing a rapid, concentrated dose. Infusions are administered over hours to days, at a continuous, controlled rate. When calculating IV drip rates, watch for the microset, which typically means 60 drops per milliliter, a common source of exam errors. Intramuscular, or IM, absorption is faster due to high vascularity, allowing for larger volumes. Subcutaneous, or SC, is slower and less vascular. IM administration of heparin is inappropriate because it causes hematoma, making SC the correct route for heparin. Metered dose inhalers, or MDIs, require shaking and slow, deep inhalation. Dry powder inhalers, or DPIs, are breath-actuated and require quick, deep inhalation. Particle sizes less than 5 micrometers reach the alveoli. Remember to rinse your mouth after using steroid inhalers to prevent thrush. Examples of refrigerated medications include insulin, GLP-1 agonists, and certain vaccines. According to CDC 2026 guidelines, all refrigerated medications must be stored on the middle shelf, centered and away from coils and walls. Never store them in the door, as temperature swings invalidate potency. NIOSH guidelines define hazardous drugs and mandate strict procedures, including double gloving and negative pressure rooms. For teratogenic tablets, crushing is prohibited, as it exposes the technician and environment to hazardous particles. Always contact the pharmacist for an alternative liquid formulation. USP less than 795 greater than requires light-sensitive medications, such as nitropicide, to be stored in amber containers. Exposure to light, like a clear bottle in a window, can lead to potency loss. Transferring these medications to a clear pill organizer reduces the beyond use date to 7 days. In this ceftriaxone example, reconstitute the vial with diluent to achieve the correct concentration. The reconstituted solution is stable for 24 hours at room temperature or 10 days refrigerated. Remember the overfill adjustment. Subtract 0.1 milliliters per vial from the total volume to prevent concentration drift. Key drug handling colors. Orange means shake well, blue means refrigerate, and yellow means take with food. High-frequency drug pairs include metformin, taken with meals, and levothyroxine, taken on an empty stomach. Omission of the avoid alcohol warning for metronidazole can lead to disulfiram-like reactions and liability. This is a placeholder slide. 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 This is a placeholder slide.